I didn't have a chance to be briefed yet this morning, but what is our audience mix like? So are we all physicians? Please raise hands. Technologists, nurses, nurse practitioners. Okay. All right. So I'm going to introduce this topic called autonomic testing, which is not easy for me already to quite grasp. So explaining it is probably not going to be a very easy task either, but I'll do my best to make it as simple as possible. And what I really am aiming from this session is to explain what these tests are and why do we use them? What do they add to the workup? And what conclusions can we draw from them? I think I have to make a disclosure for CME. I have nothing to disclose, unfortunately. All right, so let's start with the first case here, or actually the only case. So this is a 60-year-old Caucasian male who, bless you, came to my clinic complaining about for the past 18 months or so of feeling his feet being swollen. And he said that he occasionally had pain in his knees, elbows, and shoulders. He also said he had some dry eyes, some dry mouth, and recently he started noticing total impotence. When asked about his urination system, sweating, swallowing, he denied all that, no dizziness. And it's only when I questioned him further that he admitted that he had mild burning of his feet that was worse at night than during the day. Is this a scenario that sounds common to your practice? Have you seen something like that? Yes? No? All right. Neither no nor yes? Okay. So the neurological examination was normal in this man, except for borderline orthostatic hypotension, meaning a drop of about 20 millimeters of mercury systolic. And what was a little bit unusual is that we didn't see a reactive tachycardia, which we generally see with this amount of drop in blood pressure. So upon further examination and testing, we confirmed the diagnosis of something we called non-length dependent small fiber neuropathy. You've heard a little bit about this type of neuropathy a little bit earlier by our speakers. So what is this concept of non-length dependent? It's just that, normally the nerves are affected towards their distal ends. So the further away they are from the body, this is where the injury starts, and then it moves backwards. It's like lighting a cigarette, right? But there are certain conditions where this phenomenon, the length-dependent phenomenon, does not happen, and it's the reverse that happens. So the more proximal structures are affected first, and there are certain disorders that generally cause that. In most metabolic disorders, it's the length-dependent pattern that prevails. All right, so how are we going to manage this case or approach this case first? So obviously, given the symptoms, I chose to do an EMG. Probably you would have to. Sending an etiological blood work for what be the cause of that small fiber neuropathy. Doing things like skin biopsy, we'll talk a little bit about that. Maybe an abdominal fat PET biopsy, looking for amyloidosis. But also autonomic testing. So upon further testing, the EMG was normal. And the autonomic testing results came back this way. Okay, so we're going to be talking more about that. But it said, the Qsart, QSART, showed mildly reduced sweat production in forearm, proximal leg, and calf, but not in the foot. The heart rate variability to deep breathing response was low. The Valsalva ratio was low. The tilt table showed moderately severe orthostatic hypotension. Okay, so when you get a report like that, if you're not familiar with all these terminologies and what these mean, you're practically lost. All right, so why do we do those tests? What do they add to the workup? So first, when you do an autonomic test, you establish the presence or the absence of autonomic fiber involvement in the case. You can, by doing so, exclude non-organic, quote-unquote, etiologies when the autonomic testings are abnormal. And also, you can define a prognosis, because autonomic testing will be able to help you discern between a disease-based dysautonomia, which is like, for example, multiple system atrophy or diabetes, and as opposed to other conditions which we call syndromic, such as postural orthostatic tachycardia syndrome, which are generally less severe. And the autonomic neuropathy in diabetes, for example, is a very serious condition. So it's very important that we detect it early and that we treat aggressively, because studies have shown about 4 to 8 times increased mortality in these conditions. And what do we mean by those syndromic and disease-based? So I mentioned a few. So generally under the big umbrella called dysautonomia, which, as Dr. Vernino said, is a generic term, we have the disease-based, which we also call primary dysautonomias, or the syndromic that we can call secondary. And under syndromic, you see postural orthostatic tachycardia syndrome, migraine, functional GI disorders, interstitial cystitis, complex regional pain syndrome, fibromyalgia, you name it. It's a spectrum of disorders that goes from the mild to more severe. And the disease-based, okay, we have peripheral and we have central. Under central, we have MSA, Lewy body disease, for example. Under peripheral, pure autonomic failure, and small fiber neuropathy. And small fiber neuropathy has many causes, including diabetes, genetic, inflammatory, immune, metabolic, mitochondrial, etc. So when we look at those, so I said that autonomic testing allows us to discern whether there is or not involvement of the autonomic fibers. What are those? So we know that the autonomic nervous system is made of parasympathetic and sympathetic fibers. So we are able to look at the cardiac parasympathetic fibers, at the cardiac sympathetic fibers, and also at the fibers that go to the periphery, to the vasculature, so the vasomotor sympathetic, at the arterial level and at the venous level. And localize also, it allows us to localize the lesion at the level of the neuroaxis. So you heard that there are post-ganglionic versus pre-ganglionic segments in the autonomic nervous system. So for example, if we wanted to test the post-ganglionic segment, we use a test such as the Qsart, the pseudomotor axon reflex test. If we want to look at the entire sweat system between central and peripheral, then there is another test called the thermoregulatory sweat test, or TST, that can help us with that. So let's talk about that first test called the Qsart, so quantitative pseudomotor axon reflex testing, which was described in 1983 by Philip Lowe. And it tests, as I said, the post-ganglionic segments only. All right, so these are sympathetic cholinergic fibers. All right, so just a quick word about how it works. So basically, and you're going to see probably that demonstrated later on. So these are capsules which contain 2 concentric chambers. So you put one capsule at the surface of the skin. You fill the outer chamber with acetylcholine. You drive acetylcholine through the skin with an electric current. This is called iontophoresis. Acetylcholine is going to stimulate the nerve that is sitting underneath, and it's going to generate an action potential, okay, that will travel along that nerve. And then as soon as it finds a branch, it will travel down that branch to a different sweat gland. Okay, so these are sweat fibers, right? Small fiber sweat fibers. And then when it gets to that next sweat gland, the sweat gland is going to produce a sweat response, which will be collected in that other chamber, which is the inner chamber of the capsule, as you see here. And this amount of sweat, actually the difference in humidity, actually this is how we measure it, between a flow that is going through that capsule will be able to tell us how much sweat has been produced. Okay, so this is all computerized. Obviously, so this test does not give us an idea only about those nerves, but it also is dependent upon the good function of a sweat gland. All right, but the advantage of it is that it gives us a global idea of the whole postganglionic segment that is made of the sweat gland, but also of the small fiber circuitry that mediates sweat production. So because of this test, we're able to draw a conclusion about the integrity of the small fibers, particularly the small fibers, the autonomic small fibers that mediate sweat production. Okay? All right, so the other test of sweat function is called the thermoregulatory sweat test, and this is actually a fun test to do. I call it a sophisticated sauna, basically. And what we do is, first of all, the principle behind it is that we think that sweat production is dependent on the skin temperature and the core body temperature. So what you do is you put somebody laying flat in a heated box after covering their body with a powder, which is whitish, orange kind of color, made of cornstarch, alizarin red, and baking soda mixture. And then you heat the body, you elevate the body temperature, and then after, and you control for humidity, of course. And then the body starts sweating, and this powder changes color to purple. And at the end, we're all here with our cameras taking pictures and looking at the areas that have sweat and that have not sweat. And there are patterns that we can clearly distinguish and that have been very well described by Robert Feely at Mayo Clinic, who described this test. And we're seeing some classical patterns here. Okay, so one pattern which we call a normal pattern here on the left. Another pattern where you see an absence of sweating distal to proximal in the lower extremities, but also in a radicular fashion here at the level of the abdomen and thorax. So this is a radiculopolyneuropathy. You can see this in diabetes, but then you can see the typical diabetic, for example, or any other peripheral neuropathy where sweating is absent at the extremities in the upper and the lower extremities. But then if the central nervous system is affected, then there is what we call a reversed pattern, meaning that the extremities sweat normally, but the central part of the body does not sweat normally. So I'm going to go back here, and if you combine both tests, the Qsart and the TST, all right, so the Qsart will be abnormal in a peripheral nervous system abnormality, but it will be normal if the problem is at the level of the central nervous system. As we agreed on, is that Qsart measures the postganglionic segments. Okay. Now the TST will show abnormalities in both, and if you combine both, you will know you can localize the lesion as being peripheral or being central. That's an example of how autonomic testing can help us with the localization. All right, another test of autonomic function, which is commonly used, is the cardiac response to deep breathing. So if we all take our pulse, let's do that, put our fingers on our pulse, take a couple seconds, and measure our pulse. And let's all take a deep breath in, and now out, 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 out. And let's do it again. In, out, 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 out. So I hope that you all noticed that when we take a deep breath in, our heart rate goes faster. And when we take a deep breath out, the heart rate slows down. If you have not noticed that, please find me at the end of the talk. All right, so this variability in heart rate, okay, we think is under the strong influence of the vagal nerve. And doing this maneuver will allow us to come up with a ratio, which is the ratio of the fastest heart rate to the slowest heart rate, or the difference between the fastest heart rate minus the slowest heart rate. And we have standardized values here that will tell us if this cardiovagal system is normal or abnormal. All right, another test is the Valsalva maneuver. I think we've all experimented that in our lives. So basically, the test is the patient is laying there, and you ask the patient to blow against a resistance. And they maintain that for 15 seconds, and then they release. The resistance about 40 millimeters of mercury. And this creates a complex physiological response of blood pressure variability or variation and heart rate variation, which we could classically subdivide into 4 phases. And let's look at that first phase. So what happens when we blow first? So what we're doing is we're increasing our intrathoracic pressure, right? And this is creating a mechanical compression of blood vessels, and this is increasing our blood pressure. So as you see, the first phase here is an increase in blood pressure, but this is not autonomic reflex, okay? This is a mechanical, pure mechanical response. All right, so now, because the intrathoracic pressure is high, this will lead to a decrease in venous return to the right heart, right? And therefore, there's going to be a decrease in the cardiac output because of that. And because of this, blood pressure is going to drop. And this is what we start seeing here, a progressive drop in blood pressure. And if nothing happens, this drop will continue all the way down to here, and people can faint. But there is a reflex mechanism that happens at the level of the sympathetic nervous system that's sensing that drop in blood pressure that will kick in at the level of the peripheral vasculature. And we know that sympathetic at the level of peripheral vasculature is vasoconstricting. So what's going to happen is a peripheral vasoconstriction. And because of that, there will be a stabilization of that drop in blood pressure that we see here. And sometimes there is even a return to normal of blood pressure, to what was present before. Sorry? Oh, the pointer is not showing. Okay, all right. The laser up. Okay, all right. Sorry, I was talking all this time, not realizing that you're not following me at all. So this is phase 1, where we see the mechanical increase in blood pressure. And then suddenly the cardiac output drops, blood pressure drops. There is a peripheral vasoconstriction that will stabilize this drop in blood pressure here. Sometimes the blood pressure returns to the pre-blood pressure levels. Okay? And so this is called late phase 2. Now, suddenly, there is a release of that blow against the tube, and that intrathoracic increase in blood pressure, intrathoracic pressure is relieved, and the venous return normalizes. Okay, already the release in that pressure will cause a mechanical drop here in blood pressure, just as in phase 1, but the opposite. And now the cardiac output has returned to its normal value, but the peripheral bed is still vasoconstricted because of what happened before, and this will create an overshoot in blood pressure, which we call phase 4. Okay. Now, those changes in blood pressure will lead to reflexive changes in heart rate. Like, for example, when we start seeing that drop in blood pressure here, we start seeing an increase in heart rate, okay, reflexively. And when we see the overshoot in blood pressure, we're going to see a drop in blood pressure, in heart rate, reflexively as well. And so what do we conclude from the Valsalva maneuver? So there are two things that we have to look for. We have to look for the heart rate response, and then we come up with something called the Valsalva ratio, which is the ratio of the highest heart rate to the lowest heart rate. We think this is under the parasympathetic influence, cardiovagal. Now, this is controversial a little bit, but this is the most common thinking. But also, what we can all conclude from that is looking at this blood pressure pattern and know if the sympathetic response at the periphery is intact or if it is affected. Okay, so we can draw a conclusion about the cardiovascular sympathetic, and we can draw a conclusion about the parasympathetic at the level of the heart. All right, so the last common test is the tilt table test. And so there are orthostatic syndromes, and we know about three major categories here. Let me just quickly go over them. So we have something called orthostatic hypotension, which you've heard about before, which is described as a drop of 20 millimeters of mercury systolic or more, or a drop of 10 millimeters of mercury diastolic or more. So if we see this is the upper slope. This is a progressive drop in blood pressure. Normally, there should be a reflexive increase in heart rate to compensate for that. The second orthostatic syndrome is the postural tachycardia. Now, in this syndrome, we do not have a drop in blood pressure, but the blood pressure remains relatively stable. What happens is the heart rate goes up by 30 beats per minute or more during the first 10 minutes, and we call this POTS, as you know. And then we have the third orthostatic syndrome, which is the reflex syncope or vasovagal syncope, where suddenly, at one point, both blood pressure and heart rate will drop. And we say the patient syncopated, right? Okay, so this is the graph that we see on the tilt table. Here's blood pressure that is maintained. So it either goes down, or heart rate stabilizes, or it goes up in response to a drop in blood pressure, or it goes up without a drop in blood pressure. So those are the first two syndromes. And suddenly here the patient starts telling you, oh, I feel a little bit tired, and suddenly you see blood pressure plummeting, heart rate plummeting. This is the vasovagal syncope. So this test allows us to know what is the innervation status, so the cardiovascular sympathetic innervation at the level of the vasculature, at the level of the heart, to see if, for example, if the heart rate does not go up in response to a drop in blood pressure, then you know that there is a cardiac sympathetic failure. If blood pressure drops, it means that there is no peripheral vasoconstriction to maintain blood pressure, and this is a peripheral vasomotor adrenergic abnormality. So I'm going to talk about a couple special tests. One of them, which is specifically dear to my heart, is the pupilometry testing. So this is based on a very common test called the light reflex that we do in our clinics. You shine a light in the eye of a patient. The influx goes through the optic nerve. It goes all the way to the superior colliculus. It goes to the midbrain, where it synapses. First time at this level here of the pretectum. A second synapse happens at the Edinger-Westwald nucleus, and the synapse happens with the parasympathetic fibers that circulate along the third cranial nerve, synapse in the ciliary ganglion, and gives branches to what we call the ciliary nerve that goes to the iris and constricts the pupil. That's the pathway. So pupilometry, we call it pupilometry today. Before it used to be called pupillography. And this is not a new test. Actually, it was devised in 1933 by ACFA and by Eastman Kodak. I think ACFA is still around. Eastman went first, became Kodak, and now Kodak closed as well. So this is sad to say. But Eastman Kodak developed that technique. Okay, basically they took still pictures of the eyes, and then they took series pictures with slow time course and series pictures with fast time course. And when the infrared technology was applied, better pictures of the pupils were able to be taken, as you see here. Then cinematography was attempted by Weiler even before taking the pictures. So the pupil cinematograph, Reeves in 1919 worked at Eastman Kodak. He developed that technique. And then until we got to the father of modern pupillometry, it was Otto Lievenstein, 1920, who developed the modern pupillograph. By taking those kinds of series of pictures of the pupils, we can see how complicated his pupillographs were. Really, there were machineries of optic physics that were very complex. And he devised that kind of prism technique where you could see both eyes sitting next to each other and compare them. Down here, this is still being done. And you know how they used to, flash photography was based on magnesium, right? So they used to light a magnesium powder that would give a very bright light but last a few seconds and go away. And this is how they used to stimulate the pupil. And after that, television infrared pupillometry came on. This was an analog technique that measured pupil area and diameter and the percent of iris area or diameter. Until we got to the digital age, and this is what we call dynamic pupillometry with digital pupillometers. So those are machines that will scan the pupil either vertically or horizontally, this way. And nowadays, compared to the Otto Lievenstein pupillometers, you see how simple these are. So this is a small machine. You put your eyes here. A flashlight will come on, make your pupils constrict. This will be captured, and it will show on a computer screen. So it's really much, much easier. It's commercially available, easy to use. And this is the Lievenstein juxtaposition of the eyes. Also, you can see them nicely next to each other. And this is the kind of graph that you see. So there is a period of latency between the time the light comes on and the time the pupil starts to constrict. So we can measure already the initial diameter. Then the pupil constricts very fast. That's the first phase, and reaches a bottom, after which a fast redilation phase will happen, followed by a slow redilation phase. And if we look at the slopes here, we can measure the maximal constriction velocity. We can measure the maximal redilation velocity. We can measure an average redilation velocity. As I said, we can measure latency, but we can also measure the amplitude of constriction. So now we know that the latency is strongly under the influence of the parasympathetic, and when it is prolonged, it means that there is an parasympathetic tone at the pupil. The constriction phase, as we all know, is under parasympathetic influence. So this is a very strong parasympathetic tone at the pupil, and then suddenly, at the bottom of the graph, there is a withdrawal of this parasympathetic tone, so the pupil is left with sympathetic unopposed. That's why there is a fast phase of redilation, and then suddenly or progressively, that parasympathetic starts coming back again and stabilizing the strong effect of the sympathetic nervous system, which slows down the redilation phase. So when we dissect all that, we are able to know which branch of the autonomic nervous system is not working right. So in the case of our patient, the latency was prolonged, the initial diameter was smaller, the reflex amplitude here was decreased, constriction velocity was slowed, and there were some abnormalities of redilation. And the nice thing about pupilometry is because it's dealing with very short distances, very small nerves, we think it's very sensitive. So sometimes you see, or often, you see the abnormalities at the pupilometric level before you see any abnormalities with the other tests that we talked about. So it's a very nice addition to an autonomic armamentarium. And last but not least, I'm going to talk about skin biopsy. Now, skin biopsy, you can consider it as part of the autonomic testing. Not technically so, but we use it very often in conjunctions with the other tests. So basically, you take a 3 millimeter skin punch biopsy specimens that you fix in 2% PLP, cryoprotected, glycerol, and then you section them at about 50 micrometers. You immunostain them, and you look at the fibers. Here we are. So normally, that's a normal here on the right-hand side. That's a normal skin biopsy. So those small fibers are sitting around the sweat glands and doing basket-shaped whirling around them. And they also cross from the dermis into the epidermis, and you can count them individually. And there are normative data at different areas that are standard areas of biopsying. Now, this is our patient that I was talking about. And you see that there was total denervation of the small fibers at the level of the epidermis, but also at the level of the sweat glands. And the conclusion of that is that there was a small fiber neuropathy that was not only autonomic, measured by Qsart, but also somatic, meaning that those fibers that mediate pain and temperature go to the epidermis were also affected. So combining both tests not only increases the sensitivity. We did a study ourselves to look at the sensitivity of each. In our study, when I was at the Cleveland Clinic, we found that each of these tests, the Qsart and the skin biopsy, had about 50% sensitivity. Some studies have shown more than that. But when you combine them, you can go up by about 23% and get a better sensitivity. So I recommend that we combine both tests when we want to work up a small fiber neuropathy, especially an autonomic small fiber neuropathy. Skin biopsy correlates very well with the examination. This has been shown by Walk in 2007. And this is the study that we mentioned and we did at the Cleveland Clinic. So I come to my conclusions now. So autonomic testing, first you see it's not easy, it's complicated, there's a lot of physiology behind. So you need to understand all that physiology before you go and embark yourself on something like that. So we think that it should be performed by dedicated physicians who have those kinds of laboratories and can perform at least most of those tests that we're talking about. Autonomic testing can help differentiate between mimickers and narrow the differential diagnosis. Autonomic testing can help with the workup and management of these conditions, and sometimes it can help with the prognosis. And I'm done. Thank you very much.